Hello everyone and welcome to another episode of Heart Success Podcast. Today we will be discussing the American Heart Association meeting from November of 2020. We will be going over some of the important trials that came out of the study, some of the relevant results, maybe some practice-changing data, and a little bit of perspective on the first study I'll start with today is the Galactic Heart Failure Trial. It was a study that we've been waiting for quite a bit and had very high hopes for. The study itself is called Cardiac Myosin Activation with Omecamtiv mecarbil in systolic heart failure. Omecamtiv mecarbil is basically a new drug. It is the first drug of its class, actually, that augments cardiac contractility by selectively binding to cardiac myosin and thus increasing the number of force generators, that is myosin heads, that can bind to the actin filament and initiate a power stroke at the start of systole. There is data that short-term intravenous administration of omecamtiv mecarbil improves cardiac performance in some of the early clinical trials. This whole class of drugs, cardiac myosin activators, are a new class of myotropes that improve myocardial function by directly augmenting cardiac sarcomere function. Kind of sounds a little bit like mavacamten from the last episode where we discussed the ESC 2020 studies, except remember that specific drug was used in hypertrophic cardiomyopathy as a negative inotrope, and it actually decreased actin-myosin binding. So again, another drug that works at the sarcomeric level, except that this is a positive inotrope. There is some data that omecamtiv mecarbil, particularly in patients with chronic heart failure with a reduced ejection fraction, improves LV systolic ejection time, improves stroke volume, while at the same time decreasing LV systolic and diastolic volumes, decreasing plasma natriuretic peptide levels and heart rates. Some of this data comes from the Cosmic Heart Failure Trial that was published in 2016. Some of the lead authors on this study were responsible for conducting that specific study as well. Based on these results, the fact that you had beneficial reverse cardiac remodeling, reduction in plasma natriuretic peptide levels, and some improved hemodynamics, the expectation was that this may be a new drug that we can use in patients with reduced ejection fraction. And as you know, we currently have no positive inotropes that have been shown to have any outcome benefit. You could look at digoxin, maybe a little bit of heart failure hospitalization benefit from the DISH trial. That was way long ago. We are always worried about a lot of the side effects of digoxin. Some of them may be a little overestimated. And the other inotropes that we use in practice are really milrinone and dobutamine, as we all know, that are more appropriate for stage D heart failure patients, NYHA class 3B4, usually very, very symptomatic heart failure patients. Before I actually go into who was studied and what the results were, it was a positive trial. So let's just start with that fact that it was a positive trial. It was industry-funded. Amgen, Cytokinetics, and Servier were the study sponsors. And let's start with who was studied. So these are basically HFrEF patients, 18 to 85 years of age, class 2 to 4 with an EF of 35% or less. The patients who were currently hospitalized for heart failure or had made an urgent visit to the ER or been hospitalized for heart failure within 1 year prior to screening. So it was a combination of both inpatients and outpatients. There were certain BNP cutoffs and pro-BNP cutoffs, 400 for pro-BNP, 125 for BNP, higher if they had Afib, of course. And the patients had to be on guideline-directed medical therapy to get into this study. The key exclusion criteria were, current hemodynamic or clinical instability, needing MCS or mechanical support or intravenous medication, a blood pressure of less than 85 millimeters of mercury, and a GFR of less than 20, a recent acute coronary syndrome, or cardiovascular procedure, including elective procedures, and conditions that would adversely affect participation in the trial. A couple of key points in these inclusion and exclusion criteria. As you can see, the GFR cutoff of 20 is a lot lower than some of the RAS blockade agents that we use. Including patients with a systolic blood pressure of 85 and above, basically, is lower than any other drug, particularly recently. Even if you look at Entresto or SGLT2 inhibitors, their usual cutoff was 100 millimeters of mercury. So they did expand their inclusion criteria to include some of these maybe sicker populations. So who was included in the study? What's the baseline characteristics look like? Patients were in their 60s, mean age, 20%, 21% female, 77% white, 8% Asian, 7% black, 17% United States or Canada, 19% Latin America, and then looks like mid-50s Europe and 8% Asia. So really multiple different continents. 25% of the patients were from the inpatient setting, and the rest, 75%, were either ER or outpatients. Roughly 1/4 had atrial fibrillation or flutter. 2/5 of the patients had type 2 diabetes, and half and half was ischemic and non-ischemic if you look at the breakdown. Mean LVEF included in the study was 26.6%. Majority of the patients were NYHA class 2 and 3. This is not a class 4 trial. The breakdown between 2 and 3 also looks close to 50-50. It sort of looks like 53-40-43. Median blood pressure was 116 systolic, heart rate 72. Pro-BNP at entry was close to 2,000, so quite high. Median troponin at entry was 27. This looks like a high sensitivity troponin, a little bit on the higher side. Median GFR 58. So sort of a lot of patients in stage 3 CKD. Very good use of guideline-directed medical therapy, high 80s for ACE/ARB/ARNIs, 20% basically were on an ARNI, mid-90s for a beta blocker, 2.5% were on SGLT2 inhibitor, 15% CRT, 32% ICD, and mineralocorticoid receptor antagonist use was 77.6%. So that, I think, is the highest mineralocorticoid receptor antagonist use in some of the more recent trials. The SGLT2 inhibitor trials reached early 70s, and this really got it to the deeper into the 70s. So that is very impressive. This is very impressive baseline therapy. So what was the outcome of the trial? So the primary composite endpoint was cardiovascular death as first event, hospitalization for heart failure, or urgent outpatient visit for heart failure, and it was 37% in the study arm, in the study group, versus 39.1% in the placebo arm. Absolute event rate is 2.1% per year, lower in the drug arm, p-value of 0.03. So it looks like a number needed to treat of 50 every year. Interestingly, most of this difference, comes from urgent outpatient visit for heart failure, hospitalization for heart failure, and cardiovascular death. Both of them were lower in the group on the drug, but they're all very little, 0.6, 0.7% differences in the individual outcomes. Secondary outcomes such as death from any cause or cardiovascular death looked fairly similar to each other. So no direction for any benefit when it comes to cardiovascular death or all-cause death. When you look at the changes in laboratory measures and safety outcomes, nothing really stands out. Heart rate's slightly lower with drug use, -2 with the drug, -0.5 with placebo, so just a little difference there. And slightly greater reduction in NT-proBNP, -250 in the drug arm versus -180 in the placebo arm. The median cardiac troponin I increases were slightly higher in the drug arm at weeks 24 and 48 those being 4 and 2 respectively. Discontinuation because of adverse events was no different between the two studies. Serious adverse event rates were no different. Arrhythmias, no different. Torsade, really no different. With serious adverse ventricular arrhythmias needing treatment, no different. Myocardial infarction, unstable angina, coronary revascularization, essentially the same in both groups. The only difference that was favoring the treatment arm seemed to be when it came to adjudicated stroke. The stroke rates being slightly lower in the treatment arm at 1.8% versus 2.7% in the placebo arm. Not sure what to make of this. I think it's safe to say that this difference in stroke was purely incidental, as the authors don't even mention it in the discussion. To conclude the study results, in this randomized placebo-controlled trial of patients with heart failure and reduced ejection fraction, which actually studied over 8,000 patients on excellent guideline-directed medical therapy, using omecamtiv mecarbil had an 8% lower relative risk, absolute difference 2.1 percentage points, in the composite primary outcome of heart failure event or death from cardiovascular causes compared to placebo. This effect was observed without evidence of an increase in the risk of myocardial ischemic events, ventricular arrhythmias, or death from cardiovascular causes or any cause. When you look at the forest plot and some subgroup analysis, there is a potentially greater treatment effect in patients with an ejection fraction of 28% or less compared to those with an EF of more than 28%. Again, this is more hypothesis generating. I wouldn't say that's the group of patients this drug needs to be used in. I think one of the advantages is that you could use this drug in some of these NYHA class 3 sicker patients. I'm not sure if the cost of the drug is going to justify how we do it. And something we will have to get used to with this drug is it kind of is used like Coumadin. You give the patients a very specific oral dose, and it usually comes in either 25, 37.5, or 50 milligram doses. And then you check serum levels of this dose, the plasma levels of the drug. It's a twice daily drug. And you titrate your therapies to a certain goal. So interesting study, new class of drugs. I would say, positive results, but the effect size is quite small. We'll have to see whether there is a space for this drug class in an already crowded field of excellent guideline-directed medical therapy for HFrEF. The next two studies are SGLT2 inhibitor studies, and it's a new drug. It's called Sotoglyphlosin. This is different from the other drugs that you heard, those being, dapagliflozin and empagliflozin, particularly in the reduced ejection fraction arena. Canagliflozin, ertugliflozin, I do not believe there's any data for reduced ejection fraction. So, a new drug within the class of SGLT2 inhibitors. The one difference with Sotoglyphlosin is, in addition to its SGLT2 inhibition and activity, it is also an SGLT1 inhibitor, works mainly at the gastrointestinal level when it comes to SGLT2-1 receptor inhibition. Its activity at the kidney level on SGLT2 inhibition, it increases glucose excretion in the urine, and by its SGLT2-1 inhibition at the gastrointestinal level, it reduces postprandial glucose levels by delaying intestinal glucose absorption. So let's start with the first study out of the two. This is the soloist WHF trial, Sotoglyphlosin in patients with diabetes and recent worsening heart failure. It's a multi-center, double-blind trial. It was industry funded, in which patients with type 2 diabetes who were recently hospitalized for worsening heart failure were randomly assigned to either Sotoglyphlosin or placebo. The primary endpoint was total number of deaths from cardiovascular causes and hospitalizations and urgent visits or heart failure. It included first and subsequent visits in this endpoint. And the trial, unfortunately, did end early because of loss of funding from the sponsor. So let's talk a little bit about what the inclusion criteria look like. And it looked very much like some of the other heart failure trials. 18 to 85 years of age, blood pressure 100 and above. These were patients, again, like I said, recent worsening heart failure. So these are patients who had signs and symptoms of heart failure and received treatments with intravenous diuretic therapy. They were also, obviously, type 2 diabetics, known before that index admission for heart failure. Exclusion criteria was end-stage heart failure or recent acute coronary stroke event or stroke, recent PCI or CABG, or a GFR of less than 30. They did not include patients with a blood pressure less than 100 and those that needed intravenous inotropes or vasodilator therapies were also excluded. So these were patients in their median age, late 60s, female 30%, 90+% white, median hemoglobin A1C 7.1, median GFR close to 50, and patients were from Latin America, North America, Europe, so all over. The diagnosis of diabetes in roughly 10% of the patients was either within the 6 months before randomization or during the index admission, even though I know I said it wasn't allowed. 2.5% roughly were diagnosed during that index admission. These are not patients with just reduced ejection fraction. Roughly 80% of the patients had an EF of less than 50%. The median EF was 35, interquartile range of 28 to 47. So mainly it was a reduced and mid-range ejection fraction population. Median NT-proBNP 17 to 1800 in both groups. Excellent guideline-directed medical therapy in both studies. 15% ARNI use, roughly 80% ACE or ARB use, 66% mineralocorticoid receptor antagonist use, and then 90+% use of beta blockers and loop diuretics. From the standpoint of diabetes, 86% were on some kind of glucose-lowering medication. Metformin 50%, sulfonylurea close to 18-20%. DPP-4 inhibitors in 15-16%, insulin in a third of the patients, and then close to 3.5% were on a GLP-1 receptor antagonist. To go over the study endpoint, it was a positive study, even though it was cut short and did not actually complete enrollment because of funding issues. The primary endpoint of death from cardiovascular causes and hospitalization and urgent visits for heart failure was significantly lower in the drug arm compared to placebo. 51% versus 76.3%, hazard ratio 0.67, p-value less than 0.001. They had secondary endpoints in order of hierarchical testing. If you look at the actual deaths from cardiovascular causes, they were 1.9% absolute difference lower in the drug arm. Statistically, doesn't look that different. All-cause death was 13.5% in the drug arm, 16.3% in the placebo arm. Your confidence intervals do cross the midline. So majority of the difference came from hospitalization and urgent heart failure visits, honestly. The safety endpoint, serious adverse events led to withdrawal of the drug in 3% of the patients and placebo in 2.8% of the patients, not that different. The major common adverse events that occurred in the treatment arm, which is the Sotoglyphlosin arm, and the placebo arm were hypotension, 6% versus 4.6%, UTI, 4.8 versus 5.1%. The only thing that was really, I think, a little bit higher in the treatment arm was slightly higher rate of diarrhea, 6.1% versus 3.4%. This diarrhea has not been noted in previous trials. So this probably comes from the SGLT1 part of its mechanism of action. And no difference in the rate of acute kidney injury, slightly higher rate of severe hypoglycemia, 1.5% versus 0.3%. Again, this has been noted in some of the other SGLT2 inhibitor trials. When you look at the other events of special interest, really not that different. Fractures, diabetic ketoacidosis, mycotic infections, amputation, really not that impressive. So to conclude, in this trial involving patients, all of them who had diabetes, type 2 diabetes, and a recent episode of acute decompensated heart failure, Sotoglyphlosin therapy, whether initiated either right before or shortly after hospital discharge, resulted in a lower total number of deaths from cardiovascular causes and hospitalizations and urgent visits for heart failure than placebo. Majority of the benefit coming from the reduction in heart failure hospitalization. One thing I'll say is, compared to the other outcome trials with SGLT2 inhibitors, the median follow-up in this study was a lot shorter. The median duration of follow-up was 9.2 months. Median duration of treatment was 7.8 months. Early discontinuation of the trial also may have contributed to sometimes just an exacerbation of the difference. And it's hard to make any assessment on hard outcomes such as mortality when you're underpowered in this study to truly assess those. In some ways, it is consistent with the data we have. It is unfortunate that we didn't get full enrollment and a full trial, because it is possible that if we had enough events, there could have been some benefit when it came to hard endpoints. The adverse event profile seems fairly reasonable and seems consistent with what we already know from other SGLT2 inhibitors, apart from the diarrhea that was more with this treatment. The next study is a chronic kidney disease trial with cardiovascular outcomes. It's the same drug, Sotoglyphlosin, in patients with diabetes and chronic kidney disease. This study was also funded by Sanofi and Lexicon Pharmaceuticals. It's called SCORED, S-C-O-R-E-D. This was the second study that was published in the New England Journal, along with Soloist WHF and SCORED, both led by Deepak Bhatt as the lead author. So back-to-back New England publications, simultaneous publications at the time of presentation at the AHA. So the background of this study was really to explore further on the efficacy and safety of the SGLT2 inhibitors in preventing cardiovascular events in patients with diabetes and chronic kidney disease with or without albuminuria. I think if you heard the previous episode on ESC, we talked about DAPA-CKD, sort of looking at a similar population. What they did in SCORED is they included patients with type 2 diabetes, glycated hemoglobin of more than or equal to 7. The difference between the two is that DAPA-CKD had both diabetic and non-diabetic. I think the breakdown was 68%, 32% diabetics and non-diabetics. So these are all type 2 diabetes patients. They had chronic kidney disease, GFR of 25 to 60, and risks for cardiovascular disease. And they received, in a 1-to-1 ratio, either Sotoglyphlosin or placebo. Primary endpoint was changed during the trial to a composite of the total number of deaths from cardiovascular causes, heart failure hospitalizations, and urgent visits for heart failure. And this trial also ended early because of loss of funding. Interestingly, they had, despite this funding issue, over 10,584 patients that were enrolled into the study. The baseline characteristics, patients were in their late 60s, median age was 69, 44% female, 44-45% female, 83% Caucasian, and median hemoglobin A1C was 8.3 at study entry, mean BMI close to 32. Participants were from all across different continents, Europe, Latin America, North America, and other parts of the world. And, roughly 20% of the people did have an ejection fraction of less than or equal to 40%, within the past year or hospitalization for heart failure within the previous 2 years. This ejection fraction was only available among people with a history of heart failure. Roughly 10% of the people had an EF of less than 40%. Another 5.5% of the people had an EF of between 40 and 50%. And around 16% of the people had an EF of more than or equal to 50%. Prior MI in roughly 20%, prior stroke in roughly 9%, and coronary revascularization had occurred in a fifth of these patients. When you look at some of the renal parameters, you will see that the urine albumin to creatinine ratio, median ratio was 74, and 35% of the people had less than 30, and 31% of the people had a ratio of more than or equal to 300. Median NT-proBNP in the study was 196. Blood pressure 130s by 70s, and roughly 88-89% of the people came in on either an ACE-ARB or an ARNI. 15% were on a mineralocorticoid receptor antagonist. From the standpoint of diabetes, metformin was the most commonly used oral drug, and insulin was also used in 2/3 of these people, among other drugs. Just going straight to the study results. So it was a positive trial. The primary endpoint of total number of deaths from cardiovascular causes, hospitalizations for heart failure, and urgent visits for heart failure was significantly lower in the drug arm. Absolute difference of 1.9%. Hazard ratio 0.74, p-value less than 0.001. There was really no difference in the deaths from cardiovascular causes, 2.2 versus 2.4%. And when you look at progression of renal disease, defined by more than or equal to 50% sustained reduction in GFR for more than or equal to 30 days, long-term dialysis, renal transplantation, or a sustained reduction in GFR to less than 15 for more than or equal to 30 days. It was 0.5 versus 0.7%. That's a little different from the previous studies, whether you look at Credence or whether you look at DAPA-CKD or even some of these subgroup analyses from other SGLT2 inhibitor trials. It has consistently been shown to slow down progression of renal disease. The only way I can explain it is that the median duration of follow-up was only 16 months. So, treatment on Sotoglyphlosin was under less than a year and a half. And maybe we would have seen a difference if patients had continued the drug for much longer. Another factor that may have contributed, a little over a third of the patients did not have any albuminuria at all, which has been a requirement in the previous studies looking at renal function. So this may have looked at a group of patients that just wasn't as sick. As you can imagine, same GFR, but albuminuria portends a worse prognosis. So that could have been another reason why effect size may have been a lot smaller than expected. The overall side effects were not significantly different. Diarrhea was again higher in the group on Sotoglyphlosin, absolute difference of 2.5%. Volume depletion was slightly higher, absolute difference 1.3% on the drug arm. And genital myocardial infections, slightly higher, absolute difference 1.5% higher in the treatment arm. And diabetic ketoacidosis, while the absolute rates were very low, 0.6 versus 0.3%, were statistically higher in the group on Sotoglyphlosin. So in some ways, this drug showed what we've already seen. It lowered the risk of composite deaths from cardiovascular causes, hospitalization for heart failure, and urgent visits for heart failure than placebo among patients with diabetes and chronic kidney disease, irrespective of the presence of albuminuria. Remember, I think a third of the patients had less than 30 on the albumin creatinine ratio. So it has expanded use in this group of patients without albuminuria. At the same time, all the benefit came from really heart failure endpoints, not from hard endpoints. Really no difference when it comes to the overall rates of death, serious adverse events, or major complications. I think the authors rightly said that longer trials are required to evaluate the safety and effect of Sotoglyphlosin in patients with diabetes and chronic kidney disease. So some positive news, again, marred by the lack of long follow-up, and unfortunately, as we discussed, the trial had to be stopped early because of funding issues. The next study is a polypill trial. It was conducted in over 5,000 patients, and this study is different that it involved a polypill approach, including aspirin and some other cardiovascular drugs for primary prevention, and was conducted in developing countries. It's 53% India or Bangladesh, 34% from Philippines, Malaysia, or Indonesia, and 8.5% Colombia, 2% Canada, 0.7% Tanzania, and 1.8% Tunisia. So that's the breakdown of where the patients came from in this study. So let's talk a little bit about what this study did and what the results were. The assumption was that a polypill containing statins, multiple blood pressure lowering drugs, and aspirin would reduce the risk for cardiovascular disease. And they used a 2x2x2 factorial design to randomly assign participants without cardiovascular disease who had an elevated intra-heart risk score to receive a polypill that contained 40 milligrams simvastatin, 100 milligrams atenolol, 25 milligrams HCTZ, and 10 milligrams ramipril, or placebo daily, aspirin 75 milligrams or placebo daily, and vitamin D or placebo monthly. And they looked at the outcomes for polypill alone as compared with matching placebo, for aspirin versus matching placebo, and for the polypill plus aspirin versus double placebo. The primary outcome was death from cardiovascular causes, myocardial infarction, stroke, resuscitated cardiac arrest, heart failure, or revascularization. This outcome was specifically for the polypill alone or the polypill plus aspirin combinations. For only the aspirin comparison, the primary endpoint was death from cardiovascular causes, MI, or stroke. And they also looked at safety endpoints. A total of 5,713 patients underwent randomization, mean follow-up of 4.5 years, so fairly robust follow-up. And what they saw was that the LDL cholesterol was lowered by approximately 19 milligrams per deciliter. Systolic blood pressure was lowered by approximately 5.8 millimeters of mercury with the polypill and with combination therapy compared to placebo. And the primary endpoint occurred in 4.4% in the polypill group versus 5.5% in the placebo group, hazard ratio 0.79. The upper end of the confidence interval was 1.0, making this really borderline non-significant data, but trending heavily in favor of the treatment arm. The primary outcome for the aspirin comparison was 4.1% versus 4.7%. Here the confidence intervals were across the midline. The primary outcome for the polypill plus aspirin comparison was 4.1% versus 5.8%, hazard ratio 0.69, and the p-value was less than 0.05 for this specific comparison. The incidence of hypotension and dizziness was higher in groups that received the polypill. The authors concluded that combined treatment with a polypill plus aspirin led to a lower incidence of cardiovascular events than did placebo among participants without cardiovascular disease who were at intermediate cardiovascular risk. This study was funded by the Wellcome Trust. It had a high representation of what we said, underserved populations. The age was patients were in their mid-60s. Heavy representation from women. Actually, 52-53% of the patients were women, and the interheart risk score, was around 17.9 to 18. The mean LDL cholesterol in the trial was around 120, total cholesterol mid-190s, mean HDL 47 to 48. Triglycerides in the 140s, mean baseline creatinine was normal, and fasting plasma glucose a little bit on the higher side with 1-teens. If you look at the discussion, which is again fairly complicated because you had so many different comparison groups, and the only group that was truly positive in the primary endpoint was the polypill plus aspirin group. I think the author conclusion that in this large randomized control trial, the combination with a polypill, which consists of a statin plus 3 blood pressure lowering drugs plus aspirin, led to a lower incidence of cardiovascular events than did placebo among participants without established cardiovascular disease who are at intermediate cardiovascular risk. I think it holds great value, particularly because some of these drugs are cheap. Polypill makes it easier to take. Of course, helps with adherence. I wouldn't be surprised if this option became available even in heart failure. I can see a lot of patients really jumping to that opportunity. The pill burden is real. Hopefully, we will have such options available even for patients within the United States. The cost of this polycap, it was approximately $15 per month. But it's still significant if you convert that to rupees, which is I think it's approximately 70 something right now. So that's close to 1,000 plus rupees every month, which is a little bit on the higher side. So that was the polycap study. The next study we'll talk about is Rivaroxaban use in patients with atrial fibrillation and the bioprosthetic mitral valve. It's called the River Trial. Basically looked at the effects of Rivaroxaban in patients with Afib and bioprosthetic mitral valve that basically had an indication for anticoagulation, the indication here being Afib. They used renally adjusted Rivaroxaban, which is 20 milligrams daily, or 15 in patients with a GFR of less than 50, versus warfarin with an INR goal of 2 to 3. And the primary outcome was a composite of death, major cardiovascular events, those being stroke, TIA, systemic embolism, valve thrombosis, or hospitalization for heart failure, or major bleeding at 12 months. This study was entirely conducted in Brazil at 49 different sites, included over 1,000 patients, 1,005 patients to be exact. The way they analyzed it is a little different from how we're used to seeing analyses. They analyzed this using what we call the Rmst analysis, which is a restricted mean survival time analysis. This is a little bit new to me too, and maybe the first time I read about this was in one of the recent papers in JACC Heart Failure, where they were talking about using restricted mean survival time analyses in really heart failure trials because it helps patients quantify true estimates and risk assessments. I couldn't tell you exactly how to calculate it. I think there are certain ways you can calculate it statistically. It is a measure that represents the average event-free survival in a pre-specified period and provides useful information on the treatment effects. So it complements conventional measures of relative and absolute risk reductions. And my understanding is that it also assumes proportionality in the event rate. So it assumes that there's proportional hazards here. The primary outcome event occurred at a mean of 347.5 days in the Rivaroxaban arm and 340.1 days in the warfarin arm. Difference calculated as restricted mean survival time of 7.4 days. P-value less than 0.001 for non-inferiority. Death from cardiovascular causes or thromboembolic events occurred in 17 patients. It's 3.4% versus 5.1% in Rivaroxaban versus warfarin respectively. And the confidence intervals did cross the midline. The incidence of stroke was 0.6% in the Rivaroxaban group and 2.4% in the warfarin group. Hazard ratio 0.25. Your p-value was less than 0.05 here. Major bleeding was essentially similar in both groups, though numerically favoring the Rivaroxaban arm. And other adverse events were also somewhat similar. They concluded that in patients with atrial fibrillation and a bioprosthetic mitral valve, Rivaroxaban was non-inferior to warfarin with respect to the mean time until the primary outcome of death, major cardiovascular events, or major bleeding at 12 months. I think this is an interesting study. Roughly 500 people in both arms. Hands down, the largest study, and actually, I believe one of the only randomized controlled studies using a DOAC in this group of patients with bioprosthetic mitral valve and Afib. But the data is consistent with what we've already seen. If you look at some of the subgroup analyses that have been conducted from the DOAC studies for Afib, and the numbers were really low. Engage AF TIMI, if you look at Aristotle, the number of patients with a bioprosthetic valve in those studies, 31 and 130 odd in these studies respectively. There was another study with edoxaban in just a little over 200 patients. It was edoxaban versus warfarin for 3 months. They looked at death, thromboembolic events, intracardiac thrombosis, and found that edoxaban was non-inferior to warfarin in this study, in this group, and major bleeding was similar in both groups. In most of these studies, when you look at the analyses, the primary event rates seem to be lower in the DOAC arm, even though statistically they may not be different, and that's difficult to prove considering the numbers we have. But the event rates were lower in the DOAC arm, so there was no difference in mortality, I think. But the difference in stroke is quite significant. I mean, it's a 1.8% absolute reduction in stroke. There were absolutely 0 hemorrhagic stroke events in patients on DOACs compared to 5, that being 1% in among patients on warfarin. Ischemic stroke was 0.6 versus 1.4. Fatal stroke is 0.2 versus 0.4. Non-fatal stroke is 0.4 versus 2.0%. Even though the majority of the difference is coming from non-fatal strokes, all the stroke risks and all the stroke rates seemed to favor use of Rivaroxaban. While there was really no difference in the clinically relevant major bleeding scores, minor bleeding was numerically again lower in the group on Rivaroxaban. Statistically, no difference in really any major cardiovascular or bleeding outcomes. The authors concluded that in patients with Afib and bioprosthetic mitral valve, Rivaroxaban was non-inferior to warfarin with respect to the mean time until the occurrence of major clinical events. There is an interesting subset in this study. So all these other studies that I was talking to you about never included patients within the first 3 months of their surgery. A fifth of the patients in this study were randomized within the first 3 months post-surgery. And it was in this group actually that DOACs seemed to have a more profound benefit. This is purely hypothesis generating, but I think it's interesting to note that you could start these patients on DOACs as early as within the first 3 months of surgery. If you ask me, I think considering how protective we are about our bleeding outcomes and reversibility issues post any surgery, cardiothoracic surgery, I know most of the surgeons I've worked with have favored, not always, but usually favored using warfarin. May be reasonable to use warfarin for the first 30 days if that's the surgical preference, and then switching to DOAC. And if you ask me, I think all the data seems that it could be used interchangeably. But if you're a purist, Rivaroxaban has the best data, followed by edoxaban, and then minimal data for apixaban in this group of patients. Our next trial for discussion today is called Rhapsody. It's a phase 3 trial of interleukin-1 trap rilonacept in recurrent pericarditis. New drug class, new mechanism of action. So the background of this is, interleukin-1 has been implicated as a mediator for recurrent pericarditis. The efficacy and safety of rilonacept, which is an interleukin-1 alpha and interleukin-1 beta cytokine trap, has been studied in phase 2 studies with recurrent pericarditis and shown some advantage. This study was a phase 3 multicenter double-blind event-driven randomized withdrawal trial of rilonacept in people with acute symptoms of recurrent pericarditis and systemic inflammation. Now, patients presenting with pericarditis recurrence while receiving standard therapy were enrolled in a 12-week run-in period, during which rilonacept was initiated and background medications were discontinued, eventually leaving people on rilonacept monotherapy. Those who had a clinical response were randomly assigned in a 1-to-1 ratio to receive either monotherapy versus placebo right at the end of the run-in phase. The primary efficacy endpoint assessed with a Cox proportional hazards model was the time to first pericarditis recurrence, and they also assessed safety of this drug class. The study was performed in Australia, Israel, Italy, and USA. It was funded by Kiniksa Pharmaceuticals. It was actually designed by several of the authors, some of whom were employees of this pharmaceutical company. Cost of this drug is close to $250,000. It is created by Regeneron. They included patients actually 12 and above when it comes to age with recurrent pericarditis who were eligible to participate and presented with acute symptoms, signs and symptoms of pericarditis during at least a second recurrence, despite treatment with NSAIDs, colchicine, or oral glucocorticoids, or any combination. The drug itself is typically given subcutaneously, loading dose of 320 milligrams, followed by weekly maintenance doses of 160 milligrams. The run-in phase for this study lasted 12 weeks, which was a 1-week stabilization period, 9-week weaning from background therapy, slow wean, for pericarditis, and then a 2-week therapy of rilonacept monotherapy, which is when the randomization occurred. Baseline characteristics of the patients: young patients, mean age in the mid to late 40s, 55-57% female sex, 90+% Caucasian race. The cause for pericarditis was idiopathic in over 85% of the people, and the rest was almost the entire remaining patients had post-pericardiotomy syndrome and related pericarditis. Medication used in the qualifying episode of pericarditis, NSAIDs was present in 2/3, colchicine in 4/5 of the patients, and half of the patients were in some form of glucocorticoids. Duration of previous treatment with glucocorticoids was close to 19 weeks, plus or minus 36 weeks, if you look at the rilonacept arm. So really a long time use of glucocorticoids, which we know aren't great to be used in acute pericarditis because, one, even though they help, they're extraordinarily difficult to wean off, and you have to be on the slowest wean. So a total of 86 patients with pericarditis pain and elevated CRP were enrolled during the run-in period. The median time to resolution or near resolution of pain was 5 days, and the median time to normalization of the CRP was 7 days. A total of 61 patients underwent randomization in the end. During the randomization withdrawal period, which is when you actually took the patients off the classic therapy, there were too few recurrence case events in the rilonacept group to allow for the median time to the first adjudicated recurrence to be calculated. And In the placebo arm, it was 8.6 weeks. And the hazard ratio for treatment here looks like 0.04, p-value less than 0.001, so heavily favoring the drug class. During this period, 2 of the 30 patients in the rilonacept group, which is basically 7% of the patients, had recurrence of their pericarditis, compared to 74% in the placebo arm. So it's really 7% versus 74%. In the run-in period, 4 patients had adverse events leading to the discontinuation of rilonacept therapy. And the most common side effects of this drug were injection site reactions and upper respiratory tract infections. So the authors concluded, among patients with recurrent pericarditis, rilonacept led to rapid resolution of recurrent pericarditis episodes and to a significantly lower risk of pericarditis recurrence than placebo. One of the other side effects, apart from the injection site reactions and upper respiratory tract infections, was a slight increase in LDL cholesterol levels among patients who received rilonacept. And if you look at the difference, it was 124 versus 111 in their mean LDL. And similarly, triglyceride levels were also higher with rilonacept. Now, I think this trial offers the ability for you to just treat recurrent pericarditis, that is relatively difficult to treat, even needing steroids like you can see here in 50% of the cases, with monotherapy for rilonacept with very remarkable success. And when you look at the Kaplan-Meier curves, they separate right away. So, the success is also quite early and quite profound. However, it is an extremely expensive drug. I don't know how easily accessible this will be. It is also an injectable. I think that adds a certain level of complexity, you could argue. The patients that were treated with rilonacept were on it for several weeks without any issues. They do have a long-term extension study, and that analysis is not out yet. The authors concluded in this randomized withdrawal trial, the interleukin-1 alpha and interleukin-1 beta cytokine trap, rilonacept, was studied in patients with recurrent pericarditis. During run-in therapy with rilonacept, most patients had a rapid clinical response and could be weaned from other therapy, including glucocorticoids. And during the subsequent randomized withdrawal period, adjudicated recurrence of pericarditis was significantly less frequent in the treatment arm compared to placebo. We had another study introducing another agent. This drug is called Avenikumab. It is an angiopoietin-like 3 monoclonal antibody. The role for monoclonal antibodies to this angiopoietin-like 3, also called ANGPTL3, is under investigation from the lipid standpoint. It is a hormone produced by the liver. It inhibits lipoprotein lipase, which is an enzyme that breaks down plasma triglycerides and lowers LDL-C by an LDL receptor-mediated pathway. Avenikumab is one of the ANGPTL3 monoclonal antibodies, not yet commercially available. There is some data. There was a study called the ELLIPSE, HOFH, which stands for homozygous familial hyperlipidemia, phase 2 trial of 65 patients. A lot of these patients were already on a statin, ezetimibe, and PCSK9 inhibitors, but still had pretty high LDLs, randomly assigned in a 2-to-1 manner to Avenikumab versus placebo, and they showed that at 24 weeks, LDL was further reduced by 47% in the treatment arm. It dropped the LDL by another 132 milligrams per deciliter from a mean of 255. In addition, it also typically lowers triglycerides and HDL cholesterol just because of the way it works. Side effects in this study were urosepsis and one suicide attempt. So these are the 2 side effects. It's unclear if they were really truly related to the drug. The need for another drug to lower LDL becomes relevant particularly when you have patients for secondary prevention that have persistently elevated LDLs. We started with LDL cutoffs of less than 70, but we have PCSK9 trial data showing that you can safely go under 50, and you probably get a significant advantage from doing that accumulates over time. If your patient's on a high-dose statin and you added an ezetimibe, and you've gotten to a PCSK9 inhibitor and their LDL is still high, and you can, depending on the guidelines, I would say over 50 to 55, there is still a role for further lowering the LDL. Now, using this particular agent, Avenikumab, does not have any evidence from the standpoint of hard outcomes, but if we are to believe that the LDL hypothesis holds true irrespective of how you lower it, there certainly is a role for this drug, particularly among patients with homozygous or heterozygous hypercholesterolemia, where they start with just very high LDLs. This study was again published in the New England Journal of Medicine. It's called Avenikumab in patients with refractory hypercholesterolemia. It is a double-blind, placebo-controlled phase 2 trial that enrolled patients with or without heterozygous familial hypercholesterolemia who had refractory hypercholesterolemia with a screening LDL of over 70 or higher with atherosclerosis, or 100 or higher without. Patients were randomly assigned to receive subcutaneous or intravenous Avenikumab or placebo, and the primary endpoint was the percent change from baseline in the LDL cholesterol at week 17 with the drug compared to placebo. A total of 272 patients were randomly assigned to different dosing strategies, those being 450 weekly, 300 weekly, 300 every other week. And then there was also the intravenous arm, which received a dose of 15 mg per kg body weight every 4 weeks, or a 5 mg per kg every 4-week dose. So lots of different dose strategies. And I think the overall conclusion was that patients assigned to the treatment more or less had a 50% point reduction in LDL. And the incidence of serious adverse events with this drug ranged between 3 to 16%. One, it was very beneficial in lowering LDL, and as seen previously, it also lowered triglycerides and it also lowered your HDL. The effect is actually seen as early as 2 weeks, and it seems like it probably peaks around the 4 to 6 week mark and was sustained throughout the course of the study, the length of which here was 16 weeks. When you look at the actual adverse event profile, while it was more frequent in the Avenikumab arm than the placebo arm, when it comes to subcutaneous Avenikumab, the absolute increases were slightly higher UTI, absolute difference 3%, slightly higher injection site erythema, 3% again, arthralgia, 2% absolute difference, and then myalgia, 5% absolute difference. The intravenous treatment had a slightly different side effect profile, more abdominal pain, slightly more back pain, dizziness, and more nausea and nasopharyngitis. In patients who received subcutaneous or intravenous Avenikumab, few high-grade adverse events were observed overall, however. So that is fairly positive data that there were no serious adverse events. There were 2 events that it's unclear if they were directly related to the drug, but there was a death in one patient who was treated with subcutaneous Avenikumab at a dose of 300 milligrams weekly from really cardiogenic shock heart failure, and one patient being treated with subcutaneous Avenikumab at 300 every other week had sudden cardiac death. In the intravenous arm, there was one patient who needed drug discontinuation because of an anaphylactic reaction. And this patient had already a history of asthma, seasonal allergies. And this patient, the drip was discontinued. The event resolved on the same day after treatment with oral diphenhydramine, which is just oral Benadryl. None of these patients who received intravenous treatment had adverse events that resulted in death. So to conclude, we have another drug that is quite potent in reducing your LDL, also lowers some of these other markers, lowers your triglycerides, lowers your HDL, and we will just have to wait and watch for some outcome trials for this drug class. The next study is called the Early AF trial. It was also published in the New England Journal. It's called Cryoablation or Drug Therapy for Initial Treatment of Atrial Fibrillation. Now, Afib is one of the most commonest arrhythmias, affects 1 to 2% of all populations. Current guidelines actually recommend initiation of antiarrhythmic drugs as the initial therapy for maintenance of sinus rhythm in symptomatic patients. However, we know that the drugs have somewhat limited efficacy and a substantial side effect profile. Catheter ablation has been shown to be superior to these drugs in maintaining sinus rhythm and improving quality of life. However, its role as a first line in treatment has not truly been evaluated and may be the better option to go to. So the author said, previous trials of early catheter ablation with radiofrequency energy have not been very conclusive and have been limited by a high incidence of recurrent arrhythmia complications and crossover. This is why they conducted the randomized early aggressive invasive intervention for Afib, called the Early AF trial of initial rhythm control in patients with symptomatic untreated atrial fibrillation. They compared the use of catheter cryoballoon ablation with antiarrhythmic drugs to prevent the recurrence of atrial tachyarrhythmia, and it was assessed by an implantable continuous rhythm monitor. This was an investigator-initiated multi-center open-label randomized trial conducted at 18 centers in Canada. They enrolled adults more than 18 years of age with symptomatic Afib and at least one episode of Afib detected on EKG within the 24 months prior to randomization. They were excluded if patients had a history of regular use of either a class 1 or class 3 antiarrhythmic drug at therapeutic doses. Eligible patients were randomized in a 1-to-1 strategy to either catheter, cryoballoon ablation, or antiarrhythmic drug therapy. Also, after enrollment, all these patients underwent insertion of an implantable cardiac monitor, which basically detects Afib using an algorithm, which assesses beat-to-beat variability, and it's kind of like the link monitor that we use for arrhythmias today. There was a 3-month blanking period after the ablation strategy. So the primary endpoint was the first recurrence of any atrial tachyarrhythmia lasting 30 seconds or longer between 91 and 365 days after the initiation of an antiarrhythmic drug or the catheter ablation procedure. If you look at the patients that were studied, they were relatively young. Patients in their late 50s, 72% male. A third of the patients were obese. Most of them had not had a long-standing diagnosis of Afib. The median time from diagnosis to enrollment was 1 year. Paroxysmal atrial fibrillation was present in a large majority of the patients. Really, 95% of the patients had paroxysmal Afib, and the median number of symptomatic Afib episodes these patients described per month was roughly 3. And at the time of study, CHA2DS2-VASc score was roughly 1.9. Half the patients, really 55 to 60%, were on a beta blocker, 7% on a non-dihydropyridine calcium channel blocker. There was a quarter of the patients had prior use of either a class 1 or class 3 antiarrhythmic agent, and then 3% warfarin use, 60 to 65% non-vitamin K anticoagulant use. So looks like 2/3 of the patients were on an anticoagulant, mainly direct oral anticoagulants. Only 2% of the people had a previous stroke. 9% of the people had an underlying diagnosis of stable heart failure, and mean ejection fraction was basically 60%. So as expected, the ablation group did a lot better than the antiarrhythmic drug group when it came to the primary endpoint, which was recurrence of symptomatic or asymptomatic atrial tachyarrhythmia following the 90-day blanking period. 42.9% versus 67.8%. Treatment effect, 0.48 hazard ratio, p-value less than 0.005. When they looked at the actual Afib burden, it was also quite favorable for patients in the ablation group. So not only did they have less recurrence, but also the time they spent in atrial fibrillation was significantly lower. There was a reasonable amount of crossover, as would be expected. 24% of the patients in the antiarrhythmic drug group did eventually undergo ablation, particularly after recurrence of an atrial tachyarrhythmia. And looks like 11% of the people in the ablation group also underwent ablation, which looks like a repeat ablation for recurrence of arrhythmias. There was no difference in any of the secondary safety endpoints related to either the ablation group or the antiarrhythmic drug group. There were 0 deaths in the study. As is known, there were 3 patients in the ablation group that did have persistent phrenic nerve palsy, which we know is a known side effect of using cryoablation. On an overview, it looks like one of the only side effects that seemed to be a little more prominent in the antiarrhythmic drug group was pre-syncope present in 5 of the 150 patients, compared to 0 in the ablation arm. Considering that atrial fibrillation is a progressive disease, this was an impressive trial. It showed that arrhythmia recurred significantly less often with an initial strategy of catheter cryoablation than with an initial strategy of antiarrhythmic drugs, with a number needed to treat of just 4. The use of implantable recorders that was capable of continuous monitoring also enabled the trial to show that ablation results in a much lower burden of the arrhythmia. When you look at the breakdown for antiarrhythmic drugs used in this study, amiodarone was very infrequently used, and which is great. I think that makes sense because this is a group of patients, young patients, paroxysmal atrial fibrillation, not a lot of comorbidities, normal ejection fraction. So naturally, they had a higher proportion of use of class 1A drugs. Flecainide was most frequently used in 3/4 of the patients, median dose 200 milligrams per day. The other second most common drug they used was sotalol, followed by propafenone and dronedarone. Amiodarone was used in roughly 2.5% of the patients as a second and third line agent. So great study, favoring ablation again in this group of patients. Shows us that ablation can be done safely, really minimal side effects, procedure related, short procedure, particularly when you use cryoablation as your strategy. And the only thing that stood out was a very low rate of increased phrenic nerve paralysis with using cryoablation. Now, if you look at the absolute rates of recurrence of tachyarrhythmias, in this study, it was 43% in the ablation arm, and that's a group of patients, like I said, that were young, that underwent a good ablation procedure. Some of the data out there that suggests that ablation is successful in up to 70-80% of the patients in 1 year. I think using an implantable loop recorder in this study clearly enables us to identify maybe a greater proportion of Afib and other atrial tachyarrhythmias. So the results are a little sobering that, again, 2/5 of the patient, despite everything that you did, had recurrence of these arrhythmias. I think what's assuring is that the overall burden was still significantly lower. And, when you look at the percent of time in Afib, the mean percentage of time in Afib in the treatment arm was 0.6% versus 3.9% in the antiarrhythmic arm. So it was less than a sixth of the burden compared to the drug therapy arm. What we still don't know is how sustainable this is. I would expect that the sustainability of an ablation would wane over time. Also, you could apply that for somebody on antiarrhythmic drugs, so we would need longer-term trials. Young people with AFib, we need 5, 10, 15-year data. 1-year data is promising, but it is not enough. So I think those were all the studies that I wanted to go into some details and describe the results to you, maybe give you a little bit of background, some practice defining information. There was a lot of data that came out of the AHA. It was really this meeting, while virtual, was done over 5 days. There were multiple late-breaking studies. Some very interesting data. I don't have the time to go over them individually. So what I'm going to do is a little different from what we've done before. I am going to tell you these studies. I'm going to give you maybe a couple of lines on who was studied and what the result was. We'll not go into much more of details. I think if you're interested, I think this will give you the ability to actually seek out the original studies papers and explore them yourself. One of the studies was early coronary CT angiography in patients with suspected or provisionally diagnosed acute coronary syndrome, rapid CTCA. So if you look at the data from coronary CT, you have PROMIS, Scott Hart, and sort of stable chest pain patients. Then you have some of the ED data. You have Ramacat, some of the other studies in the ER for acute chest pain, which also show that you can get people out of the ER a lot faster. You can maybe save some costs by using that strategy. Not a lot of data showing great use for coronary CT in patients presenting with ACS. Now, it makes sense, if you have patients presenting with ACS, chances are they're going to end up in the cath lab. This is a study randomized roughly 1,750 patients, 1 year of follow-up, mean age 62. And these patients had a suspected or provisional diagnosis of ACS with at least one of the following, which is prior history of coronary heart disease, troponin more than 99 percentile, abnormal EKG. And, gray score was pretty low. It was less than 109 in 44% of the patients, and it was over 140 in a quarter of the patients. Basically found that the primary outcome of all-cause death, or MI, or stent thrombosis at 1 year occurred in 5.8% in the cardiac CT group versus 6.1% in the usual care group, p-value 0.65. Across subgroups, really no difference. Invasive coronary angiography for cardiac CT versus usual care was hazard ratio 0.81. Coronary revascularization, no different in the two groups. Median length of stay, no different. Short stay overall, you can say, 2 days in close to 2 days in both groups. And median healthcare costs were trending to be a little higher in the cardiac CT group. So the authors concluded that among patients presenting with suspected or provisional ACS, cardiac CT angiography did not reduce the incidence of death or subsequent MI. Cardiac CT was associated with a modest increase in length of hospitalization and healthcare costs. It's hard to show outcome benefit using cardiac CT in ACS. Time will tell. We'll see. There was another study, a Canadian study called the SEARCH-AF. It was a late-breaking trial presented, and the incidence of post-operative atrial fibrillation after discharge from cardiac surgery is really not well defined because we don't have continuous monitors that look at these patients. So that's basically what they did. Patients without AFib post-surgery, randomized, half of them, 160 in each group roughly. Half of them got 30 days of 24/7 monitoring using a patch-based monitor. The other got usual care. And they found that, the patient group that got 24-hour monitoring, AFib was detected at a rate of 10 times higher than those who received usual care. Or atrial flutter lasting more than or equal to 6 minutes occurred and detected in 19.6% of the patients from the monitoring group versus 1.7% in the normal care group. Now, I don't know what this means. We're saying that we can detect more atrial fibrillation, particularly within the first 30 days after cardiac surgery. What do we do with this information? Do we need to, monitor them for longer? Do we treat this with anticoagulation? Do we use antiarrhythmics? I don't know the answer to that. So I think this study shows us that there's a lot more Afib than we previously anticipated or even knew, which is quite interesting. Management decisions based on this information will have to wait. We had a pretty large randomized controlled trial on intravenous iron in patients at discharge after acute heart failure. They used ferric carboxymaltose, which is really the drug of choice in some ways. It's called a firm AHF. It was done at 121 different sites. It was a study that actually had 1,132 patients randomly assigned. Half of them got ferric carboxymaltose, half of them in the placebo group. And, overall, the study showed what other studies using IV iron have showed. That, patients who are stabilized after an episode of acute heart failure, treatment with ferric carboxymaltose was safe, and it reduced the risk for heart failure hospitalization with no apparent effect on the risk of cardiovascular death. There was really no difference in the overall rate of serious adverse events between placebo or ferric carboxymaltose. This formulation of iron really seems among the most safest based on all the data available. It's also more expensive than, let's say, ferrogluconate, which is significantly cheaper and more often available on formulary in your hospitals. One last thing, the LV ejection fraction cutoff in this study was less than 50%. So I think they expanded this cohort of patients with heart failure. I think it's, again, consistent with showing that there's symptomatic benefit probably and there's decreased heart failure hospitalization. No hard endpoint benefit from using IV iron. That's what I tell my patients too. Another study looked at vitamin D and fish oil to look at whether it lowered the risk for atrial fibrillation. Now, there's always a craze around vitamin D, using vitamin D, omega-3 fatty acids. Joe Rogan himself is not immune to this. He'll go around touting the benefits of vitamin D in without any real benefit in scientific literature supporting that or any robust evidence, let's put it that way. The study's lead author is chair of the cardiology department of the Schmidt Heart Institute, Dr. Christine Albert, who presented the results. To summarize, it was basically a study of more than 25,000 men and women from all over the United States without a history of atrial fibrillation. During a period of more than 5 years of follow-up, 3.6% of participants were diagnosed with atrial fibrillation. There was no statistically significant difference between the participants who were assigned to take either vitamin D or fish oil supplements and the participants who were assigned to placebo. Study concludes that although these two supplements do not prevent atrial fibrillation, there is data that lifestyle modifications, losing weight, getting active, exercising, really data from the Australian group, which showed a marked reduction in atrial fibrillation recurrence and end burden. Controlling your blood pressure, moderating alcohol intake may lower the actual risk of atrial fibrillation. Using sleep apnea, controlling your sleep apnea. So I think that's where we need to focus on and stop focusing on vitamin D to solve our problems. An interesting study was the Alpheus Trial. It was a randomized international multi-center study, enrolled 1,800 patients, adults, average age 67%, mostly male, in 49 European centers that had heart disease with relatively stable disease undergoing elective PCI, and they were randomized to either getting clopidogrel versus ticagrelor. And basically the study showed that, there was no difference between the two groups. The actual risk of severe complications, including stent thrombosis, stroke, and death, was way under 1%. It was actually 0.5%. So overall, this study showed no difference in outcomes whether you use clopidogrel or ticagrelor in a relatively low-risk population. This is contrary to what I've seen often, unfortunately. I think a lot of these patients with stable coronary disease are being put on ticagrelor, maybe from aggressive marketing, I don't know. But again, more sobering results for ticagrelor in another study. Moving on to our next trial. The next study is a very interesting study. It really dealt with MINOCA, which is myocardial infarction with non-obstructive coronary arteries. We know that women actually have a higher proportion of non-obstructive coronary disease despite presenting with NSTEMI or ACS. So the Women's Heart Attack Research Program, the HARP, is an international multi-center study to assess the mechanisms of MINOCA and to try to find the cause of heart attack in these patients. They had 301 women who experienced a heart attack but did not have prior obstructive coronary artery disease, no visible blockages on the angiogram, median age 60 years, 50% non-Hispanic whites. They underwent two studies. They basically underwent a coronary optical coherence tomography, which is OCT. It's performed in addition to the angio, which uses light waves to take near photographic quality images of the blood vessel walls. You can see the intima and the media very well using this imaging technology. We use it in transplant patients sometimes to look at the intimal thickness because of coronary allograft vasculopathy. In cath, it's used for stent optimization, lesion verification, looking at the plaque, lots of other things. And they also use cardiac MRI, which shows areas of the heart muscle that have been injured. Right? That is basically late gadolinium enhancement, scar formation, and whether this injury is related to decreased blood flow, inflammation, or another reason. So patients got both these tests, and the results were quite impressive. The results from the OCTs and cardiac MRIs explained why women had symptoms and blood tests consistent with heart attack for 84% of the study participants. That's a very remarkable number. 3/4 of the women with abnormal OCT or cardiac MRI had evidence of heart damage from reduced blood flow. The arteries often had either ruptured plaque or recently ruptured plaque as a cause of heart attack. This is akin to a typical heart attack with blocked arteries, but the important difference, of course, is the plaques that are ruptured were smaller than what you would see in a typical heart attack. Cardiac MRIs showed evidence of heart damage related to reduced blood flow in more than half of the women, and in 2/3 of those with a causal finding on OCT. So there was some correlation there. 21% of the women, the cardiac MRI actually showed myocarditis, or another reason for heart dysfunction unrelated to artery blockages. For the remaining 16% of the women, both OCT and MRI were completely normal, and the reason for the heart attack was not identified. So I think this is an interesting study because it tells you that even though the angiogram in a lot of these cases is completely normal, that's not the end of the workup. That because you may want to go ahead and get maybe a cardiac MRI, maybe you want to ask your interventional cardiologist to get some IVUS or OCT imaging for you to get a little more information. I will add that they didn't really tell us much about coronary flow reserve, which also may be interesting to look at by both either cath lab and MRI to consider in these patients. Treatment remains challenging. We're still trying to understand this disease better since it affects a significant number of women before we can go ahead and start talking about how to manage these problems. But a very, very interesting study. Now, a large randomized controlled trial using omega-3 fatty acids was also performed in patients at high cardiovascular risk. It's called the STRENGTH Randomized Controlled Trial. It's called the effect of high-dose omega-3 fatty acids versus corn oil on major adverse cardiovascular events in patients at high cardiovascular risk. Over 13,000 patients randomized. Trial was stopped early because daily supplementation with omega-3 fatty acids compared with corn oil resulted in no significant difference in the composite outcome of major adverse cardiovascular events. This is different from what we know from REDUCE-IT, which basically used a formulation of EPA. The formulation used in this trial was a combination of EPA and DHA, and it's interesting why this study was negative. Now, it's hard to say. There are some arguments, if you look online, that this may have been related to the fact that it was corn oil that was used as a placebo control in this study compared to mineral oil that was used in REDUCE-IT. You can look at online editorials, some grand round presentations which argue heavily against how use of mineral oil as a placebo in the other study seemed to impact the study results. Again, I don't know how they can explain the fact that patients in REDUCE-IT actually did not have the same, changes in CRPs and LDL that we're used to seeing with appropriate statin use. But, there is some data out there that mineral oil does not seem to impact these factors. Food for thought. I think, I personally don't think the data on using EPA is as strong as it is for some of the other agents we use today, and needs a little more clarification. And this is another study, using combination of this formulation that showed negative results. And at the end of the day, there was a greater rate of GI adverse events among people who got the omega-3 fatty acid. So another nail in the coffin for use of just high-dose omega-3 fatty acids. I guess EPA, which is eicosapentaenoic acid, remains the last man standing in this sort of group of drugs. Hopefully, we'll get a little better data on that specific therapy in the future. There was another fish oil study, the Omami Trial. It was conducted in Norway, which investigated whether adding 1.8 grams of omega-3 fatty acids to standard treatment after a heart attack in elderly patients would prevent new cardiac events. And, they included over 1,000 patients, ages 70 to 82, 29% women. All of these patients had a heart attack within the previous 2 months. Most of these patients, as you can imagine, were on statins, and a lot of them were also on blood thinners. 2 years of follow-up basically found that there was no difference in the actual rate of major adverse cardiovascular events, roughly 20% in both groups. So omega-3 fatty acids, big no-go in this group of patients. For some reason, they also saw more Afib in the group that was receiving the omega-3 fatty acids, roughly 7.2% versus 4% in placebo. It was not statistically significant, but there was a trend towards harm there. An interesting study was the study that looked at patients taking statins and placebo, trying to nail down whether statins actually are poorly tolerated. It is the Samson trial, self-assessment method for statin side effects, or nocebo trial. It was intended to measure patients' self-reported symptoms during a 12-month period of randomly alternating months of statin use, placebo, and no medications. Study was conducted in London and enrolled patients who had previously taken one or more statins but stopped taking them because of side effects. Roughly 60 patients completed the study, involved 4 months of statin, 4 months of placebo, 4 months of neither. And they only used 20 milligrams of atorvastatin. There were no ups or downs in that dose. They were given 12 jars, 4, 4, and 4. And the study participants tracked the intensity of their symptoms daily on a smartphone and ranked them on a scale from 0 to 100, 100 being bad. The participants could stop the tablets for the month if their symptoms became intolerable. What did the researchers find? They found that 90% of the symptoms that were reported when patients or participants were taking a statin were also reported when patients unknowingly took the placebo tablets. Patients were just as likely to need to temporarily stop placebo tablets due to intolerable side effects as the statin tablets. Points to a psychological rather than pharmacological effect of statins, as noted by the researcher. So, not to take away, I think patients do suffer. Patients are actually reporting side effects. They're having side effects. But it is reassuring that in some cases you may be able to re-challenge them or counsel them and discuss, particularly, in patients that really need to be on these statins, whether or not they could tolerate them. So reassuring results that not all side effects from statins are related to statins. Silver lining is that 6 months after the participants completed the trial, half of them had restarted taking a statin medication and were still taking it. So these were patients, as you remember, started off because they couldn't tolerate their statins. There was a biodegradable drug-eluting stent study which showed that this new stent at 1 year was not inferior to standard of care, being Xience or Promus durable polymer stents. We know from absorbed data that the biodegradable stents took a little bit of a hit. This stent is specifically designed to actively restore endothelial function after stent delivery using a combination of rapid sirolimus delivery and a bioresorbable PLGA drug carrier polymer that dissolves after 4 to 6 weeks, leaving behind just a bare metal stent. Thin strut stent, 80 microns, and includes a layer of inert EG coating that promotes endothelial growth and avoids hyperplasia. So 1 year results promising non-inferiority, favoring the stent. There's going to be more data. There's going to be more long-term data as well. So more about this stent later. If I remember, it took absorbed 3 years to start showing the negative results. So time will tell with some of these newer stents, particularly the biodegradable polymer stents. The next study basically compared 1 month dual antiplatelet therapy followed by aspirin monotherapy after drug-eluting stent implantation, 1 month DAPT. So, they showed that actually 1 month of DAPT was not inferior to 6 to 12 months of DAPT at preventing adverse ischemic and bleeding events. It was a randomized parallel open-label study. Patients undergoing PCI for stable or unstable ischemic heart disease were randomized to either duration DAPT strategy. The 1 month DAPT group did receive a polymer-free drug-coated stent, BioFreedom, and the 6 to 12 month we received a contemporary drug-eluting stent, Biomatrix or Ultimaster. 3,020 patients randomized, 12 months of follow-up. Those with acute myocardial infarction, very complex lesions, shock, or previous arrest were excluded. And the primary outcome of cardiac death, non-fatal MI, target vessel revascularization, stroke, or major bleeding at 12 months was fairly comparable in both groups, 5.9% versus 6.5%, p-value less than 0.001 for non-inferiority, 0.048 for superiority. 1 month DAPT appeared preferential for stable PCI, and maybe there was some preference in the subgroup analysis for using longer duration for patients with ACS. There were numerically fewer bleeding events in the 1 month DAPT group as expected. Maybe again, longer therapy for unstable coronary artery disease. You can get away with just 1 month of dual antiplatelet therapy for people with more stable coronary artery disease, particularly with this stent. So very interesting results, and more to come. We'll see if this impacts any guideline changes. It's a relatively small study. More data on using a Xiopatch from iRhythm, ambulatory monitoring patch for detecting atrial fibrillation in moderate risk individuals. FDA has already cleared this device. It basically showed that patients who using the Xiopatch were more likely to get diagnosed with atrial fibrillation. It was over a long amount of time, so you have to wear the patch for that significant amount of time. And then one of the analysis showed that people diagnosed with AF who underwent active monitoring compared to the control group, which did not undergo active monitoring, the event rates were much lower in the group that had more proactive diagnosis of Afib using a Xiopatch. Active monitoring also led to fewer hospitalizations for bleeding, and the primary safety endpoint, which the incidence rate again was less than half in the group that received the Xiopatch. They also had fewer total hospitalizations. This is the mSTOPS study, basically showed that active screening for AF as part of a prospective, pragmatic, direct to participant and nationwide study was associated with a significant improvement in clinical outcomes and safety at 3 years relative to routine care. There was the video screening for atrial fibrillation using single lead EKG in the Vital AF trial. This used Cardia technology. If you guys have seen it, it's a tiny little, looks like a little flash drive with where you can put your fingers on, and it detects your pulse and uses an algorithm, which I don't understand, to come up with what your electrocardiogram should look like. They used this device to actually detect atrial fibrillation. They screened older adults at primary care visits using a live core single lead EKG device that has an interface with either your smartphone or your iPad. And unfortunately, they didn't find any significant increase in detection of AFib within this high-risk population. So that was interesting. And none of the other endpoints were also that different, be it, new initiation of anticoagulation or stroke, among others. There is the EPIC heart failure trial, small trial to look at whether patient activation tool would help intensify guideline-directed medical therapy for heart failure. And, they randomized 290 patients. 145 were given patient activation tools. 145 were basically controls. And patient activation tools here appear to be a 3-minute video and a 1-page checklist delivered electronically 1 week prior, 3 days prior, and 24 hours prior to a cardiology visit. Basically, what it showed is that from immediately preceding the cardiology clinic to 30 days later, 49% of the patients in the intervention arm and 29.7% in the control arm experienced an initiation or intensification of their guideline-directed medical therapy. So, this tool can actually, delivered electronically prior to the visit, can actually improve clinician intensification of GDNT. I think it also takes away from some of the learning and some of the discussion that you have to have with the patients, because this allows the patients to research some of these things on their own before they come for the visit, making your visit more efficient. So it turns out to be a very good strategy for intensifying guideline-directed medical therapy for HFrEF. Briefly talk about Fidelio DKD study. They presented a subgroup analysis within the cohort of patients with and without cardiovascular disease to see if the effect of finerenone in chronic kidney disease patients and type 2 diabetes depended on the underlying presence of cardiovascular disease. So just a little heads up, this is a new drug. Finerenone is a non-steroidal, selective mineralocorticoid receptor antagonist. And there is some data that it reduces albuminuria in short-term trials in patients with CKD and type 2 diabetes. There was really no long-term data until very recently. 20 days ago, New England Journal of Cardiology publication, 5,700 patients with diabetes and type 2 diabetes and CKD get 1-to-1 finerenone versus placebo. And, these patients did have elevated urinary albumin to creatinine ratio, 30 to 300, GFR range of 25 to 60, and diabetic retinopathy, or they had much higher albumin to creatinine ratio, 300 to 5,000, and a GFR of 25 to 75 range. All these patients were treated with renin-angiotensin system blockade prior to randomization. And, the primary endpoint was a composite endpoint in time to event analysis, renal failure and sustained decrease of at least 40% in the GFR from baseline or death from renal causes. Median follow-up of 2.6 years. It was a positive study in favor of the drug. Absolute difference, if you look at the absolute rates, was 3.9%. Comes to roughly a number needed to treat of 25 patients. Hazard ratio 0.82, p-value 0.001. Relatively similar amount of adverse events in both groups except hyperkalemia needing discontinuation of this drug finerenone, slightly higher at 2.3% versus 0.9% in placebo. So this study really showed, in patients with CKD and type 2 diabetes, treatment with finerenone resulted in a lower risk for CKD progression and cardiovascular events than placebo. The subgroup analyses, which looked at the presence of underlying cardiovascular disease, also showed that, the benefit on composite CV outcome and renal progression occurred irrespective of the presence of underlying cardiovascular disease. The last trial I think I'd like to talk about today is the Minnesota Resuscitation Consortium's trial on out-of-hospital cardiac arrest and resuscitation using early ECMO and angiography and PCI in these patients. But I think a lot of it really does come down to early ECMO. There was a paper roughly 4 years ago published by the group at the University of Minnesota, led by Dr. Dimitris Yiannopoulos, and as part of the Minnesota Resuscitation Consortium, where they implemented an advanced perfusion and reperfusion life support strategy designed with the intention to improve outcomes for patients with out-of-hospital refractory ventricular fibrillation or ventricular tachycardia. They did report 3-month outcomes of 27 patients, and this the methods really was 3 emergency medical services serving the Minneapolis-St. Paul metro area participated in the study. Patients between the ages of 18 and 75, and body habitus that you could actually use the Lucas device, which is a machine that performs CPR. And, estimated time to the scene to the cath lab was less than or equal to 30 minutes. So you had to have both to get included in the study. That 27 patients, these were patients who had really refractory VT arrest, which was defined as failure to achieve sustained return of spontaneous circulation after treatment with either 3 direct current shocks and administration of 300 milligrams of IV or intraosseous amiodarone. They were transferred to the University of Minnesota, where emergent advanced perfusion strategies, which is basically ECMO, and then they got a cath and a PCI if needed. And what they showed was among these 27 patients, 18 met the inclusion and exclusion criteria, and then ECMO was put in 83% of these people. There was a high proportion of coronary artery disease, and 2/3 of these patients actually received PCI. 78% of the patients survived to hospital admission, and then 55% survived to actual discharge, which is 10 of the 18 patients. 9 of the 18 achieved good neurological function. There were no significant ECMO-related complications. The idea is bridge to recovery. So this was more of a feasibility trial that the current study was set on the background of. On the heels of that previous publication, the same group now performed the first randomized clinical trial in the USA of ECMO-facilitated resuscitation versus standard ACLS treatment in patients with out-of-hospital cardiac arrest and refractory ventricular fibrillation. So it's only shockable rhythms. The trial itself is called the Rmst Trial. It's a phase 2 single-center open-label, adaptive safety and efficacy randomized trial. The inclusion criteria are fairly similar to what we just said. Refractory VFib, 3 shocks, and then using the Lucas device, estimated transfer time was again shorter than 30 minutes. Patients were randomly assigned to early ECMO-facilitated resuscitation or standard ACLS treatment. Their primary outcome was survival to hospital discharge. Over the course of what looks like roughly 9 months, 36 patients were assessed for inclusion. 6 of the patients were excluded and 30 were eventually randomized, 15 and 15 to each arm. 1 patient in the ECMO-facilitated resuscitation withdrew from the study prior to discharge. Mean age 59 years. 83% of these patients were men. And then if you look at the outcomes, survival to hospital discharge was seen in just 1 of the 15 patients in the standard ACLS group versus 6 of the 14 patients in the early ECMO-facilitated resuscitation group. 7% versus 43%, so an absolute difference of 36% in the primary endpoint. The study was terminated at the first pre-planned interim analysis. It was an early termination of the study. And the idea was because the posterior probability of ECMO superiority exceeded their pre-specified monitoring boundaries, so it was considered very efficacious. Cumulative 6-month survival was also better in the ECMO group compared to the ACLS group. The conclusion was that early ECMO-facilitated resuscitation for patients with out-of-hospital cardiac arrest and refractory VFib significantly improved survival to hospital discharge compared with standard ACLS treatment. This is an excellent trial. Shows you the advantage to achieving reperfusion early on. And ECMO does that. ECMO perfuses all your organs and to a degree gives you a reasonable amount of flow in your system that gives you a blood pressure and the ability to use other mechanical support devices or use coronary angiography and PCI in this group of patients. Again, it's a small group of people, but if one center could randomize 30 patients in a 9-month period, I think expanding this across multiple centers could achieve quite a significant benefit. I think the cost, the resources required, the coordination required. What about in the middle of the night? Can you get people to the cath lab in less than 30 minutes? Distance, this probably is achievable only in a city or a metropolitan area. So lots of questions, lots of challenges, but the start of something very interesting. And I'm hoping maybe if we can get the team who did this study in to talk about this, maybe one of our future episodes, that would be great. Because what they've started is quite novel and could work in a lot of different healthcare systems. That's all I have today. Thank you for listening. We did go over a lot of data, so many different facets of cardiology covered in one great meeting. Thank you for listening. If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestion for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. We are also now available on Amazon Alexa. So go ahead and ask your Alexa to play Heart Success. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.